I just completed my MBBS and I choose emergency medicine as a specialty during my later stages of my graduation. It's mainly due to loss of a family member to an accident and realized how simple measures at an early stage would be helped to save lives. So also this was a double flow for me. One is a loss of family member, and there was a lot of confusion for me also what exactly I need to do. So at the time, I just anyway completed MBBS. In the final years of my MBBS, this is what happened. Then when I entered my internship, it was a big confusion for me. I really don't know what exactly to do. But in my mind, I wanted something where I want to do some things where it can save lives. So when I started the internship, I think we posted in 15 days in one specialty, 1 month in one specialty. It was a bit confusing what exactly I need to choose. But my mind was running, let me do something to save lives in the initial period, initial golden hour or golden minutes, what we talk about it. At that time, whatever it was, only things was something called critical care. There's nothing called emergency medicine.
Right.
So, okay, let me do critical care to save lives. So somehow I passed, completed my internship, and my father was, uh, at the time of the accident, along with my mom, which passed away, my father had multiple fractures. So he was pressurizing me for to go to orthopedics. So, okay, and got a seat in BMC, went for almost 10 days. And at that time, the first emergency medicine program was announced in India at Hyderabad, Apollo. That is in collaboration with the Royal College of General Practitioners, if I remember. It was in 2000. So before the 2, 3 years, I was working in St. John. So there was some little bit of emergency medicine practice. So I started liking, learn some procedures at that time. So when this announced, I told I don't want to continue anymore because in those 10 days, what I realized, there were so many orthopedicians. At that time, I'm talking, and there was so much competition between those orthopedicians in the medical college time. So I realized, come on, yeah, so many people are there. So why again I should be one more competent with these people more and fighting for patients or fighting for procedures. Then when this program happened, I just took a bus, went to Hyderabad. Had an interview with Dr. Hari Prasad, who was my HOD at that time, who was the first person who went to US, completed emergency medicine, and came back and started the emergency medicine program in India along with Medvarsity. So the relation with Medvarsity went from long time, which they started the career for all the budding doctors at that time, where nobody knows what is emergency medicine. And every hospital, it is being called as casualty. So there's nothing called emergency departments at all. So Dr. Hari Prasad came back and just made it, no, come on, let's start emergency medicine at Apollo first time. And we were the first batch students. And we had a very tough time at that time. Like it's very difficult for a people to accept, oh, there's a separate specialty, because it was not by the government of India or MCI or national board, it was not there. Okay, then finally, some of the programs started. We had a tough time with all the specialists at that time because the reason why it was all manned by anesthetist. The emergency department was all manned by anesthesia or it by orthopedicians or maybe some surgeons. So it was a tough challenge for us, like how to convince them. And somehow anyway, we just made our path at that time. It was a very challenging to convince because we are going into their field and they were not
Right.
accepted. Example, all the procedures was done by anesthetist. So the day I still remember, I went and put a central line. The anesthetist started coming and giving me so much fear. Hey, come on, yeah, if it is a small thing, you can kill the patient. They started giving us so much fear, like you can't do, you people are not trained. But Dr. Hari Prasad stood with us, and with the program, which is well designed by the Royal College of General Practitioners, we started going through the curriculum and it helped us a lot and gained a confidence. And that 1 year changed my life. So there I was able to decide, come on, what exactly we can do in life. And later I came back to Bangalore, and there was one Sagar Apollo was there at that time, started the emergency department first in Bangalore with the
Okay.
corporate sector I'm talking. And if it was like well accepted by all specialty. Yeah, it was difficult challenges in the beginning, but it was well accepted. We did a lot of wonders at that time. Then the first membership program announced in India in 2004. So again, I came back to Hyderabad and we did the program membership of Royal College. It was called as MCEM. Now it is changed as MRCEM.
MRCM.
The FEM really helped me a lot of path towards the MRCM. It really guided me well. And I know what exactly I'm trying to go with that specialty because there was no other guidance. There's no textbook much. No people know what is emergency medicine. It was only Dr. Hari Prasad at that time for us. And later, what we started with the FEM, the MRCM made it very easy. So I think we almost around, I remember 110 people we joined. The party was so tough for us. The reason why it was tough, we don't know what exactly emergency medicine. They're going to ask in the preclinicals. So how we used to study for this common entrance exam. We used to mug up those questions and go, but there was no clinical scenarios.
Right.
So that is where nobody was able to pass. So somehow the first part B over, finally when the part C, there was only 20 people. And finally, I was the first person to pass at that time. It was the first course in Asia. So later, the curriculums improved. We started writing up the questions, the books, how it's going to be helpful for the next thing. And it became, then after that, I also did one of the fellowship program from Stanford. Then after some time, I started realizing, come on, I need to do something different. So I thought, let me do, because what I felt is emergency medicine, you can learn a lot of admin skills because there's a specialty we can interact with all departments, all non-medical departments.
Right.
So I thought, let me do administration. Then I went to XLRI Jamshedpur. I did the MBA in General Hospital Management. Then I did from IIM Bangalore one more program. It all helped us so much in managing the emergency department. So this is almost like my 4th year in Apollo Hospital in emergency department and continuing still. So whatever the programs which I did, we started, and so many people are getting the benefits out of this.
Exactly, sir. Such an inspirational talk here because you did all the difficult part and made it easy and made a path for the people who would like to, go forward with this as an emergency specialist doctor. And I'm sure the transition period would have been very difficult because letting everybody know there's a different department altogether from being a critical care specialist or from an anesthesiologist. I'm sure it has been a very difficult journey, but you have done a superb job there, sir, and you have made it easy for the people who are coming in for it.
Not only me, so many people, there was a team of people. See, example now, at that time when we were trying to convince the Medical Council of India and the National Board, there was no specialty. So I really tell, when we started the first career at Apollo Hospital, there was nothing called as an ambulance services. There was an ambulance, it's more of just a transport vehicle, I can tell, with a siren. So at that time, first we started something called as a hospital on wheels. So where we want to take the hospital to the patient, that concept came when we started emergency helpline at that time. And disaster management, nobody knows about it. So there were so many disasters happen in Hyderabad. I still remember around one building collapse of 348 people which had it. And we all treated those people, and that there were some deaths were there, and we all emergency physicians managed, and most of the people went home well. So there's so many learnings which happened. At that time, the specialists were very, very reluctant. But when we started showing them, they were so happy. Their job we are reducing. Let them do their more job in their own specialty. There's so many good things they can do. So most of the earlier thing, just leave it. And we started convincing. And now all that muck we have cleared it. What the problems of initial stage. Now it's a golden opportunity for the youngsters. Come go with the great things of learning the procedures to saving our lives. There's no problem, not much of a problem with fighting and trying to convince the people.
Absolutely, doctor. So I see an emergency medicine specialist as a savior, as superheroes. And as you were talking about golden hour, which is very crucial for a specialist as well as the patient. What do you think a specialist should have a personality like?
See, one is about early. I told in the thing, it is used to called as casualty. It took some
Right.
time to everybody know what exactly is the emergency medicine specialty is. So after the continuous talks with the Medical Council of India and National Board, the Medical Council of India, I think they started the MD in 2009.
9.
The MD first program started in India with only 2 medical colleges. Later in 2014, the National Board started the DNB program. And we were the first people to start in Bangalore with 8 seats. And we wrote the complete curriculum from the Society for Emergency Medicine India. We wrote the curriculum for the National Board. By this, so many things started changing. The name changed into emergency departments now. But I think with the present government, what they announced, these are all what I can talk related to people started realizing during the COVID. Till that, it was a very tough time to the government to know what exactly is emergency medicine is. The COVID taught everybody what emergency medicine can do wonders. And the only department which worked, not only department, many other department worked. The highest what worked during the COVID is all emergency physicians.
Right.
It changed all over the world what emergency medicine people can do. And they were the people in the forefront for every patient. And later the government also realized, come on, this is what we required as emergency medicine to be recognized. And now they announced, I think around 645 medical colleges, there has to be emergency medicine departments. Without that, they can't run the hospital. Now all the medical colleges started running and opening the department, but where is the people? Where is the specialist? So now as the people started knowing, there's a huge difference what we talk about a golden hour. When we started in 99, we were talking about golden hour. It is no more a golden hour. It's called the golden minutes now.
Right.
The golden minutes, what we all need to really push towards it. Initially, when we talked about a golden hour to golden minutes, we started doing some basic procedures. We started with the basic IV cannulation. Okay, that's what your job is. Then later started with some catheterization. Now what we are talking is, we are talking everything. We won't involve a specialist until the patient is resuscitated, stabilized, diagnosed, evaluated. Then we are involving the specialist. Earlier, I can tell you, emergency department was posted by multiple different specialist doctors. It used to be more of a police station, I can tell you. Okay, you come, you go there, you go to this, you go to this, you go to this. It's no more like that. A stroke patient come within that golden hour, what we talk, within that 60 minutes of 3.5 hours, we need to thrombolize. In that 60 minutes, we need to get the evaluation done, start the thrombolysis. That's what our targets we are keeping. The 3.5 hours, we don't know when the stroke happened. And this is where we started changing. Earlier, it used to be in the ICU, what they used to thrombolize. Now in this golden minutes, we started thrombolizing in the ambulances now.
Right.
That is what the difference. The MIs, the ACS, we started doing the thrombolysis, most of the patient en route from most of the outstation, we started thrombolizing in ambulance with monitoring.
Right.
Now, whatever we talk about the cardiopulmonary resuscitation, early nobody, it was not much of a training. Now we are able to do resuscitation en route everywhere. The bystanders, we are training them and they are able to do. The emergency physicians can do any, and now they are the leaders in any resuscitation skills. So many things I can talk about every specialty. It can be every disease specific in emergency medicine, the golden hour, which the golden minutes and emergency physicians can handle. And I can tell in a simple word, it's not one disease. It's from pediatric to geriatric. Everything management comes in the emergency medicine, and there's a only specialty where we have to know from the pediatric to geriatric. Everything. That is one about a medical aspect. Plus, we need to know from the housekeeping to the lab to the administration. So all these things is combined as what we talk about emergency medicine, and these are all involved into this golden hour. How quick we are going to assess, how quick we are going to diagnose, how quick we are going to stabilize. That's what going to be the life of the patient. We can talk a simple thing about the brain, the cardiac arrest patients. Within 3 minutes, we need to make sure that the oxygen, the blood should go. So this is in seconds what we are going to resuscitate. More than that, whatever you're going to do, the brain is dead. This is where emergency physicians can do things wonder. How quick they're going to resuscitate and save the life. If you do after 3-4 minutes, whatever you do, the brain is dead. Nothing is going to happen anywhere in the world. This 3 minutes or 4 minutes, what we talk to save somebody's life, no other specialist can do this wonder. And that's the satisfaction what we get out of this.
Absolutely, doctor. So I said it right that you guys are saviors and superheroes, no less than that. So, doctor, we have very enthusiastic attendees today with us, and they do have few questions. Can I take few questions, doctor?
You can go ahead.
So, Dr. Chelam would like to know, he would like to know about the emergency drugs and uses.
See, now when we started, there is the list of emergency drugs. It used to be around a list of 20 when I started. We used to make it up all the resuscitative medicine. It starts from your adrenaline, atropine, so many medications I can talk in the emergency medicine, what we keep as a card. People should know, sorry.
No, so doctor, please carry on.
Okay. So these medicines are so useful. Only this in seconds, our mind should go. When you go and read about, example, an adrenaline in a textbook, there's 6-7 pages. It's very difficult for us to remember. You need to know the few basic things. First, know what exactly this drug is. What is main indication? What is main contraindication? And the dosage, not in a milligram, it has to be per kg body weight milligram, so that you can start treating from pediatric to geriatric. People start up 100 mg, 200 mg. No, start learning about 1 milligram per kg body weight. So that what happens with the body weight from pediatric to geriatric, anybody can talk. So the drug list, if I can go, it goes up to almost around 40 to 50 drugs. It's very important just know the few basic lines, and that's going to be really helpful. The main important drugs, we keep it up as high alert drugs, as emergency drugs, starts from adrenaline, atropine, cardron, vasopressin. So many things are there. No, this is what it can be with one drugs. The classifications of these drugs. It can be started with controlling blood pressure, reducing heart rate, resuscitating things. So explaining about each drug, if I started to go for hours, right? So it's going to make a huge difference. This is where we are going to make a difference in life than any other specialties. And we are going to decide at that time what it's going to be. Most of the time, when during a cardiac arrest scenario, I've seen in my hospital also, when we stand there, it can be anesthetists, it can be cardiologists, it can be physicians. They just depend. Okay, no, just leave it to emergency physicians. They are updated with their skills and knowledge, so let them go with it. They're not going to talk. Early, it used to be the cardiologist is the boss, the physician used to be the boss, anesthetist. Now, this is what the difference in emergency physicians can do.
Absolutely, doctor. So, Dr. Anwar would like to know, I want to come into emergency medicine from internal medicine. What should I do? And he's a DNP in general medicine.
Nowadays, if you really look into after the MCI started the MD programs, which I told now around 634 medical colleges, which they required the emergency department, and where is the specialist to train the people. So the recent discussion which the NMC took over, we are in touch with them, where it's going to be getting make it up, where they are putting into internal medicine specialists, the orthopedicians, the surgeons, including the gynecologists, to come and train the emergency physicians. But I always tell one thing, where I think most of the people, you would have worked for a few months in a hospital, but when they come into emergency medicine, it's very difficult. No doctor can manage emergency department except an emergency physicians. The reason why, because it's a complete different field. We can go and manage an intensive care very easily because it's more of an observational things. It's very difficult for them. One is about the quickness, what we do. Nowadays, so many internal medicine people, anesthetists, are changing their specialty. They're not continue with their experience and coming and doing emergency medicine. And there's a huge scope for them to go and settle faster. See, there are internal medicine, anesthesia, surgeon, there are thousands of people. There's a huge competition, which already they know. So I always tell, please think and choose a specialty where doctors are required and patients require a doctor, not just with the fascination of ortho surgery like that. And before that, I always advise one thing. after they see 5.5 years, we do MBBS with internship. There it is highest thing is more of theoretical, what we have done more than a practical thing. The time we come out to one hospital, again, most of the people, they start reading for NEET exam. Again, go directly into the PG program. The practical exposure is a question mark, and they study so much and write a NEET exam. They wanted to do medicine, and suddenly their ranking will come down, and they go, okay, whatever the seat has come, let me take it. But what exactly you wanted, you're not doing. You're doing something what an option they have given. That's not should not
Right.
be an option. First, always I tell, once you finish MBBS, just go work for 1 year in a hospital. Work in a multi-specialty hospital. You will see all specialty people working. Work with them. You will come to know what exactly you're going to be good in. If you're very good in surgery, you're good in orthopedic, you're good in critical care, you're good in pediatrics or emergency medicine. That is where you're going to learn the competition, the problems, what that specialists are feeling, only you can understand with working with them. Not way keep going into the entrance. Okay, I want to do medicine. I got anatomy seat. Let me take it free seat. No, that's not the way. That's how the doctor's quality will come down. What you like, what you love, please go with it. For that, you just work for 1 year. And I always advise, go and work for some 1 year. When there is a golden opportunity in this 1 year, along with one certificate, don't expect too much of any of the emergency medicine program. Even I can talk about the FICM. Don't expect too much. You just work for 1 year. Join the program. You will be learning all the specialty, number one. Simultaneously, you are also getting one degree, one certificate. That's the advantage always we need to think. Then you will come to know, can I continue into emergency medicine? If it is too stressful for me, let me change it. Can I go into ortho? Can I go into surgery? That's how we need to plan our life.
Yes, doctor. So, Dr. Deepak here would like to know, can a physiotherapist make a career out in emergency medicine?
A physiotherapist as of now is not considered as the medical fraternity for a doctor. So emergency medicine options is not there, but there are certain admin courses are there, I think. So there is an option what now which is coming as sports medicine, which is going in a big way, which people require. So emergency medicine is a part of it. If you remember early before the COVID, there was nothing called the doctors used to be there in any of the sports event. Now before the COVID also we started. Now recently the COVID came up, and whatever the IPL to everything, we were the medical partners with emergency physicians on the ground. It starts from cricket, the pro kabaddi. Now most of the whatever happens sports event, they want the doctors. But what I've also realized, the doctors can do wonders in saving a life, but the physiotherapists can do wonders in making those cramps to all those things in the ground. So if they do sports medicine, it's the emergency medicine in that specialty. As of now, it's not there is a subspecialty in India, but in most of the abroad it is there. But we are planning to get those things here, maybe starting shortly. I request Medvarsity to do something where it's going to be benefit for so many people.
Absolutely, doctor. So, Dr. Sinha would like to know the eligibility for emergency medicine.
See, as of now, if I talk about the eligibility, early there was only two programs what used to run. One is the MRC, MCEM, and the FEM. Now, as the end program started and the DNB, that goes directly through your NEET exams. The MRChem and the FEM, we have an interview. I think there are few centers across India in Apollo's. It's running. It's in Bangalore. It's in Hyderabad. It's in Chennai, Delhi, and Mumbai. Actually, I think all these places there is a HODs. I think most of the people who's trained emergency medicine and these programs are running. They do an interview. They assess the doctors. Are they capable? They explain what exactly is emergency medicine is. And once they are capable, once they feel everything, they have a small interview with a small entrance sort of a thing. And if they are good, they will be getting the course for FEM. The MRCM, again, we have a small interviews along with the entrance exam, which is done in the hospital, not related to the NEET. So post MBBS, the emergency medicine, they can join. It's like any other specialty.
Absolutely, doctor. So, Dr. Mohit here has the same question what we are here for today. That is, he wants to know the future and the scope in emergency medicine.
If I ask Dr. Ahmad, sorry, I didn't get his name.
Dr. Mohit.
Mohit, what is the future of orthopedics? What is the future of surgery? What is the future of internal medicine? It's all question mark.
Right.
Everybody feel there are so many physicians, so many orthopedic they have done, they've all settled. We are just looking into that and we are thinking it's the opportunity to settle. But with my experience, I'll tell you, when nobody was talking about emergency medicine, now more than every batch we have around 60 to 70 doctors who study in Bangalore. I'm talking in one center of Apollo Bangalore branch. So why I talk emergency medicine future is superb. Reason because there's only finger count people in India. If you recently see, the UK people are continuously requesting they want emergency physicians, and most of the people who pass the FEM they do, then they do MRChem, and they're all 80% to 90%. The time they pass, the next day they are in UK because all the labs are exempted. They get the direct GMC registration, they get accommodation. All these things are happening. So it's very good opportunity because the doctors are less, number one. Number two, as the government of India announced, 640 medical colleges need to have emergency medicine department. Where is the doctors? I know what is outcomes because I go for inspection as an MCI, I go for an ABH. I also, as a national board examiner, I keep going and looking into all these centers. There is not that every internal medicine surgeon and orthopedic wants to come and stay in the ER. No, they don't want. If somebody is not very successful in their specialty, they may come and settle here. If somebody is very successful in orthopedic, do you think that orthopedician will leave his specialty and come and stay in emergency medicine? No. What I have seen, the people who is not able to sustain their, most of the people are coming. But yes, nowadays, as the opportunities are big, that's why I'm seeing internal medicine people also. Anesthetist I'm seeing. There are so many orthopedicians. They're all coming into emergency medicine doing their specialty. There is a huge requirement of emergency physicians across India, number one. Huge requirement all over the world. The Gulf, they're requesting, UK, so many people. One, I'm talking abroad, but talking in India, I'm talking only the medical college is 640. In Bangalore alone, we require more than around 10,000 emergency physicians. Where are they? I can tell you in Bangalore, hardly around 100 people are there now. So there's a huge scope for the people who do probably either 10, 15 years or 20 years is a huge scope for emergency medicine. As the critical care is not yet announced, I think National Board recently announced, and also with the Medvarsity program, so many people are doing. Once that also clicks, like this is a separate specialty that will click. But it's a huge opportunity for all of you.
Absolutely, doctor. So we do have few more questions. So Dr. Prakash would like to know, is it a good branch to choose over general medicine?
I can urge because again, general medicine, what happened now, the competition has become so much. I ask everybody a single question now, like when we do an MBBS to general medicine, internal medicine has become almost equivalent to MBBS nowadays because so many super specialties, sub-specialties have come into picture now. Now, I always ask, okay, what exactly an internal medicine guy can see? So I asked some people a question like this. So they told me, sir, we can see all the fever patients. There is something as your own family member come with a fever. There is an ID specialist sitting, an internal medicine guy sitting, whom you take to. Sir, I take to ID specialist. If you have a respiratory problem, pulmonologist or internal medicine, sir, pulmonology. If you have a BP, blood pressure problem, a cardiologist are you. If you really go in depth of it, there is so many subspecialties and super specialties have come now. Without those things, internal medicine is equivalent as an MBBS, or you need to just open one clinic and sit. I don't think it is really work out because highest number of clinics have been done by Ayurvedic people. So I really won't advise those things. Internal medicine is a very good specialty, no doubt in that, but until and unless you do again a super specialization, or else it's going to be a very tough challenge for you. Or if you want to do rural service with your internal medicine, it's going to be a good opportunity because the doctors are less. So I urge emergency medicine is the best for another 15-20 years than any other specialty as of now. Not
So,
just to become emergency physician. I went across all the things. I keep interacting with all the specialty. On that basis, I'm talking.
absolutely, doctor. So Dr. Ramakrishna here would like to know a little bit exactly the same thing about future of emergency medicine, but in the world of super specialty.
See, the emergency medicine, we used to talk as one specialty now. So now I can talk, the future is very good, no doubt in that. Now what is happening is in emergency medicine, the subspecialties we started now. Example, in Bangalore, we started post-emergency medicine, infectious disease for emergency physicians, first time in India. This is what happened the post-COVID. Now, the COVID time, the ID specialist, if you talk, it was finger count all over India. And only who can handle this the best is emergency physicians. It can be starting from COVID to any communicable diseases. Anything you can talk, emergency physicians can handle. So we started the infectious diseases subspecialty. Already there is emergency medicine, pediatric subspecialty, which is already running in CMC Velo. There is neonatology they are planning. We are already planning into emergency radiology because we do ultrasounds now. We don't require radiologists now.
Okay.
Do most of the ultrasounds in the ER, starting from any procedural to diagnosis we are doing. Yes, we are not able to, we are not authorized to give the report. I don't want report. I want diagnosis. A patient comes with a trauma, I do an ultrasound, I see a free fluid. How much time I'm going to save immediately, I can get plan for a surgical evacuation. A patient comes, I want to put a central line. Earlier it used to be all the blind method. Now I'm using an ultrasound to put ultrasound guided central line. Within few seconds, we are doing it now. There's so many things advanced, which is happening with emergency medicine. The intubations, all the blind method. Now we have a video laryngoscope, which we do it. If I talk about the procedures, what every specialty, the burrow we are doing in the ER, starting any fractures reduction we are doing in the ER, any shoulder dislocations we are doing in the ER. We don't require orthopedicians now. Starting from the blocks, nerve blocks to everything, we started giving in the ER. So anesthetists, now their work we are cut on. Initially they were upset. Now they're so happy. Let me improve in my specialty a bigger one. That is what they are also happy and we are happy. The opportunity with the super specialties, very happy. Now, most of the super specialty they ask, it can be nephrology. Sir, put off a dialysis catheter in the ER, it happens quicker. So they are also helpful, and we are going to compete with all the super specialty better, along with our subspecialties which is coming. Now, disaster medicine, there's one more subspecialty which started. If I talk about, there's more than 10 subspecialty in emergency medicine is started. In abroad, there is many. In India, it's taking time and it's going to be starting very faster.
So Dr. Anil here would like to know, he's a surgeon, and how can he go forward with emergency medicine?
If he has already completed his MS surgery, I always advise do your 1-year program. First, get oriented, do your fellowship program, because see, emergency medicine is a complete different challenge subject, I can tell you. If I talk about a surgery, you're going to do surgery. If I talk about pediatrics, you're going to study the whole pediatrics part of it. Here, you need to know the pediatric to geriatric, everything. I'm not talking that we need to know the masters of everything. We need to know the basics of saving a life from pediatric to geriatric. That's where we are going to play a big change in the medical field. Yes, surgeons, you can do it, but I always advise choose at least before. See, I won't advise everybody to directly jump into MRCEM because I have seen the pass percentage is less because I would have completed my MBBS 3-4 years back. My preclinical knowledge would have come down. And the major part is preclinicals where we need to pass. So first understand what exactly is emergency medicine. What is the core we need to learn? Because emergency medicine is related to practical exposure than theoretical. 80% of our lives plays with the practical exposure. Our patients are our teachers. 20% is theoretical. Example, simple one thing I'll tell you, you would have seen the MI patients. If you see one MI patient and go back and read ACS, it's a 10-page, a small word, you can't even understand much. You can't remember everything. You keep seeing 10 patients, the patient is going to teach you. What is my clinical presentation? What is my investigations you're going to do? What features I have, clinical features, positive, negative clinical findings. How is the patient presentation? How I put the patient in? What angle is comfortable? What medicines did the seniors put? What investigation they started? What was the diagnosis and what is the next line of management? If I keep seeing 10 to 20 patients, and I learned something, go back and open the book. Within seconds, you will understand what exactly you need to learn. So here, that's why I keep telling 80% is practicals, 20% theoretical. So anybody can do, but I always advise do a program, then come into emergency medicine, it's going to be beneficial.
Sir, what about the personal life in emergency medicine? Dr. Rahul would like to know.
Everybody feels that emergency medicine is the most stressful life. No doubt in that it's a little stressful life. But as a doctor, I feel for every doctor, they have their own stress. There's nothing that emergency medicine is something bigger. Yes, in the beginning stages, when you're learning, you feel little stressed because you need to learn so many things. But I will tell you, it's not that whatever we thought in the earliest, yes, initial stages, there was no, I'll tell you, when I was studying, there was nobody to train us. There's no material. There's no textbooks much. We don't know what exactly to do. Any specialist I go ask, I don't know. They talk in the neurosurgery, orthopedic surgery in their own way, not to emergency medicine related thing. If you would, example is anatomy, when we go and read it, the whole anatomy upper limb, there's so many pages, but there is something called as applied aspects, small boxes used to be there. That's what is important. Those applied aspects, we need to put it into our day-to-day activity. The example, the shoulder dislocation will come. What everybody do, just go immediately to the reduction, give some painkiller, send. Where are we putting our anat physio back in here? You start analyzing, I need to put what exactly those muscles are involved in your anterior dislocation, posterior dislocation, your what nerves will damage, what vessels will damage. These are all anatomy. Just put those applied aspects into your patient, you'll become the best emergency physician. And it's not here stressful. Why? Because once you started knowing, no, it's the most easiest department. Little timings I can understand. The main stressful where I see is with the patient attenders. Here, where this is a only department where the patient attenders are inside and we have to keep doing. Believe me, initial days, yes, you may get a little stressed because you're afraid. What exactly they're going to do? Some patient attenders come, they're very good. Some patient attenders just find faults in you. Some patient attenders scream at us. But believe me, these are all the learnings for us. And this makes us a beautiful emergency. See, I always combine emergency medicine as the army personnel, the Javans. We are like Javans. Any war, we are on the forefront. A bullet comes, it will be taking. Even if a war wins, we won't get much credit of it. It's the back officers. But the happiness and satisfaction what emergency physician get, no other specialist can get. People come with a pain, we make them to laugh and send. People in a scenario, we make them alive and send them back. What else happiness we can get it in than any other specialty? It's not that stressful, whatever the people used to think. Earlier days, because there's not much of the training programs, there's not much of equipments, because see, who knows ultrasound mission is going to be in the ER. Now, as things are going, you have ultrasound, video laryngoscopes are there, all the central line easy methods, ETCO2. If I talk, there's so many things. Those stress, what we used to see, is come down. If you really go back and read, there's so many articles about abroad, there's a lot of stressful for emergency patients because the doctors are less there. So 10 people work, they're getting with 2 people. In India also it may happen, but as more people start choosing this, their life is going to be the good. So don't consider stressful. And number 2, always people ask, sir, I'm a lady doctor, can I do? If you come and see her, 80%, 70% are lady doctors who is doing. So there's no differentiation. Everybody can do it.
Absolutely, very well said, doctor. The whole aim of today's session was exactly the same. Why should they choose emergency medicine? So Dr. Samita here would like to know, how is it different from critical care medicine?
See, the emergency medicine is the quick thing, the quickest way of assessment, evaluation, diagnosis, management. Once we do everything stabilized, patient comes, a simple thing I'll tell you, a patient has come with a stroke. The history is taken, the features are taken, his examination is done, evaluation is done, by investigation is done, diagnosis is done, thrombolysis is done. All the management is over. Now the patient is going to be monitored to see any further complications which happens later. So intensive care is more of an observational area. Later the complication, what happens, that management. Here, everything is quicker of doing the first thing. Not first thing, I'm talking the first to end. Until the patient diagnosed, management is done, stabilized, and shifted out. Later, any further complications happen, that is what they're going to be managed. It can be the post-operative care area. It can be like any infections, the post-management. So I always, that's why I told you, emergency physician can easily manage the critical care, very easily, because I worked for almost 4 years into different ICUs. It was so easy for me. I feel like, come on, it's the most relaxing area compared to emergency medicine. Here, you need to be on your toe, and that really pushes your adrenaline and your satisfaction you can't even imagine. So uh, it's both the specialties wise, it's more of observational area and a closed environment what you manage. Here it is a quicker environment which you manage do in front of everybody. So the advantage is I won't do wrong. I keep update myself. I learn up to date. There it's a closed area. What good thing, what bad thing you do, nobody knows. That's the difference I can tell. And I'm not putting the critical care as by, it's beautiful specialty, but as of now, only the national board which started the program, but it requires so much more recognition where more critical care people need to come. As of now, managed by internal medicine, anesthetists, these people are managing. But abroad, it's a complete different specialty.
So what are the career options in abroad?
There's a huge opportunity, except US where it's a mandate for your ASMLE, but even what I have seen with our here, what we do is first, so many people directly join for MRChem, but I always advise first decide yourself. Just because there is something easy opportunity, don't jump for it. First, you need to know what exactly emergency medicine. For that, there's a golden opportunity of 1 year programs. Do that. If you feel, yes, I can continue my career into emergency medicine, then go with a 3 years program. Sir, why 3 years, one more? Come on, yeah, you're lifelong going to be emergency medicine specialist. So what is 3 years, 4 years? Nothing will happen. And our people wanted everything very quicker. If anything comes quicker, there's no value. Learn everything and become the best. As if you see the UK, you can see Australia, you can see any of the countries, there's a huge dearth for the emergency physicians. The time MRChem passes in India, the next moment they're calling, during the exam time, they're calling now people, there is an opportunity in this university, that university. There's a huge scope abroad. Very easy way of settling, but I always tell my people, please do service for some time in India and then go. Get exposed over there. There's a huge requirement in India, emergency physicians. So at least for the sake which our country has given medicine to you, do at least few years and go to abroad if you're keen on that.
So we have spoken about the career option. One of the doctors would like to know about the settlement, about salaries.
Okay, now if I talk about the salaries again, every question, see, early when we used to study, we never used to talk about salary. We used to talk how much I'm going to learn.
Right.
Every day, everybody will ask at first is what is the stipend? What is the salary I'm going to get the future? If I talk about what the present scenario going on with the donation seats, the management seats, it's very high. I can't even imagine. The MBBS seats is going with a management of some 1 crore, 1.2 crores. I don't know. And PGs is talking around 2 crore, 3 crore, 4 crores. I'm really surprised. And even the free seats with the fees of 25 lakhs per year. But the people now, they started looking when there is something opportunity with a little amount, they're thinking, sir, I want stipend. Anyway, it's okay. That I think people need to realize first learn, then your 100 years life will be settled. Don't always compromise your life for 2-3 years for some amount of stipend and put your education down. First 2-3 years, concentrate on learning. MBBS, whatever we have learned, believe me, if I really give a small child to you to resuscitate, it's very difficult because we have not learned the practical. Put your efforts now than money, learning skills, number one. Number two, there'll be some opportunities. Don't worry, everybody will get a very good opportunity. Now, if I talk about, everybody will ask her the salaries. Always we need to compare what does an MD and MS guy, the post MD MS, what they get in India. I've seen in my hospital, there are more than 40-50 registrars with MD MS who works here. Their salaries are around 50 to 55,000, 60,000 rupees per month for the first 3 years until they become a senior registrar. The senior registrar gets around some 80,000 rupees. I'm talking, it may differ 5-10,000 rupees with each hospital. Once they become a junior consultant, it will be around some 1.2 lakhs or 1.5 lakhs. And as a consultant, it may go from 2 now. If you go to the rurals where there's no doctors, it may start with 1 also for you immediately. But again, it all depends with you, or if you want to be in urban area or rural area. Some doctors ask me, sir, are you ready to be in rural area? As of now, I am not going to go there. Reason not because I'm against of it. I am against because there's no availability of the facilities. I don't learn medical
Right.
facilities.
Medical facilities.
I want all the specialists to be there. So if I work here, I keep meeting from pediatric to geriatric, every specialist daily, so that I can exchange my knowledge. I can learn so many things from them. I can update myself. There it is very difficult. So they need to start more of the bigger hospitals, then things may happen. So the salaries are very good compared to any other specialty. I can tell you. I think I've seen with the post our fellowship program, people are getting even up to 80 to 90,000, even 1 lakh I've seen, which MD people are not getting. Post FEM. With the MRCM, there's a very huge requirement and the salaries are extremely good. Some hospitals start with 1.5 to 2, where a junior consultant level post MDMS will get it. So I'm telling, this is what happens. Depends on the hospital.
Right.
But don't run behind it. First, run behind your education and learning. After that, 100 years, your life is settled with good amount of money. For a short money, if you sacrifice your learning for this 3 years, later 100 years is going to be a tough challenge for you.
Absolutely, doctor. So who's the best to tell about Dr. Kavi would like to know that in case she couldn't crack NEET PG and to get MD in emergency medicine, how about joining Medvarsity by SEMI or MEM by SEMI or 1-year fellowship program for emergency medicine? Do you think how the scopes are there for these kind of fellowship programs and everything? So
see, what I always advise any doctor, see, I am also was a president of SEMI, now I'm a past president, that we started some MEM program. The MEM program is not a degree, it is more of a training thing. It's a training, that's what it is called as CCT. It's just a training and certificate is issued by the board. Because some people won't get any opportunity, they want to learn, and just to learn things, they're going to be there, number one. I always tell the doctors, do something, either Indian recognized program or international accredited program. The reason, because some value. I'm not saying international accredited is 100% accepted. Example now, there are so many. If you talk about MRCM, MRCP, MRCOG, all are international program accepted by MCI, was also with your NMC. Like that, there are some proxy, any post-graduation is called as 3 years. Less than 3 years is called certificate program. So don't think it's a post-graduation, number one. Number two, any certificate program is updating your skills and also improving your CV, improving your own, getting more degrees. All things happen simultaneously. So I always advise again and again, do something Indian recognized program or international accredited certified program. So I always advise people, go with the 1-year program first. Why? Because don't jump into 3 years. If you're getting through NEET exam MDC, please take it up. If you're not able to get it that time, first go with your 1-year program. First understand the specialty first. Because if you go on in your medical college of 5.5 years, whatever your work, there's emergency medicine, 15 days, your program there, they would have posted. What you would have learned? Nothing. And it's more of a casualty practice in medical school still now. Now they're going to change into emergency medicine. So emergency medicine is completely different than what we learn in medical colleges. If you go and ask your seniors, they don't know what exactly is emergency medicine. They don't know what to teach you. So that's the reason I always advise, first work for 1 year, do simultaneously this program. You get a very good exposure. The curriculums are good. I'm not here to promote only the FEM. I'm here to promote about the emergency medicine here. It's a good opportunity. Think about it. 1 year you're there. No, it is very stressful. I'm not able to take the stress. Please change that time. At that time, advantages, you're not losing anything. You got one certificate. You got all specialty learnings. Even if you want to go to pediatrics, you would have learned pediatrics. You want to go into surgery, you would have seen the surgery here. You would have learned all the basics, which is going to be helpful as your continuation of your career. If you feel, yes, this is a beautiful specialty, I continue now 3 more years, then your life will be settled. That's what I always advise. Don't jump. There are so many in-hospital programs are happening. Please don't go for it. Even if I tell Apollo is doing in-hospital program, don't join for it. Because there has to be some university, some body which is going to take up all this. Like how Medvarsity is there. Medvarsity is affiliated with the Royal College of Liverpool, also now with the Royal College of General Practitioners. This is where, because the curriculum is also set by them. So they set the curriculum along with their experience of UK to India. This is where we can learn better. And the exams, I think they're all coming here. They do the exam. We
Right.
learn the best. We learn the best way of international standards to our standards also. So I always advise, do any international certified or Indian recognized program.
Absolutely. So I think it can be more like a stepping stone. You're getting the exposure regarding the department. And I think in the long run, it will be very helpful for everybody.
100% I can tell.
So thank you so much, Doctor, for taking out time, taking this wonderful session, clearing everybody's doubt on all the aspects. And I'm sure that everybody here have cleared the doubts. And if you would like to see the particular fellowship program, please do visit www.medvarsity.com. And yes, the recording will be there on assimilate.one. So if you want to see the recording, please visit www.assimilate.one. So thank you, Doctor, taking out time, taking this wonderful session for all of us. And thank you everyone for joining us today and clearing your doubt. I hope you have all cleared your doubt regarding emergency medicine and you have a better view about it. So thank you, Doctor. Have a good day. And thank you, everyone.
Thank you very much. And I thank and congratulate and I give all the best to all the budding doctors. And I always tell, choose emergency medicine for your future. As of now, it's a good opportunity. I don't know after 15, 20 years what's going to be, because the competition will seem like what in other specialty.
Right.
Now it's the golden opportunity. Jump and take it. And always one thing I tell, when something is there ready in the hand, nobody knows the value of it. So this is what I'm telling. Things are ready. You have any doubts with you, anything's required, I think Dr. Kritika just gave my mail ID also to all of them.
Absolutely, Doctor.
Whatever their doubts I can clarify. I'm very happy if those people do emergency medicine and go save somebody's life. I'm the happiest. I don't want anything else. I don't want anything else. If you people are going to able to go save somebody's life, I'm not telling that other specialists not saving a life, but here it's a different way of saving a life, and only the people who are there in this field can understand the value of it. That's what I tell. All the best for all of you, and all the best for the future.